Hi, everybody. It's Susan Clinton and my co-host Erica Mello, and we're here with podcast number. What number are we today, Erica?
141. Yes.
141.
And
Yeah,
yeah,
and
I mean,
we're both laughing at it because it's
we're
like,
both
wow, we're
living
really up that far? That's
141.
crazy.
Yeah, and this is an episode about a lot of people have dysfunctional thoraxes and dysfunctional trunk pelvis, but it's not painful. However, the topic that we want to talk about today is people who have thoracic drivers and their relationship to poor foot and hip control.
Yep.
And it's a topic that has been, woven throughout many episodes over the years that we've done this, and we really wanted to sort of hone in on the nitty gritty on this as well. And so, just a quick thing: if anybody, I thank you to all of our new listeners, and if anybody has not left us a review on Apple Podcasts, we would really appreciate it. It's a way that we can be found. And if you found value and really enjoy the podcast, please feel free to leave us a review on wherever you listen to podcasts. And for those of you who have not gotten any of our clinical pro PDFs and great sleep tips and persistent pain PDFs, please hop onto the website, toughtotreat.com, and you'll see a list of all of the episodes. And if you have a special topic you want, you want to hear about, just type it in the search bar and all the episodes that we've devoted to that topic will come up. So on to the episode.
Welcome, everybody. Episode number 141, Tough to Treat. I'm Susan Clinton, your co-host, along with Erica Mello, my co-host. Hi, Erica.
Hi, Susan. How are you?
Doing well, doing well. December, snow on the
December's on
ground.
us.
Yeah.
You have snow. We don't have snow yet.
I
That's
think you're
nice.
getting some, though. I think some's on
Yeah,
the
I
way.
hope so. I love snow. I really do.
So anyway,
Um,
chilly December afternoon or midday for us. And we thought we would jump in, as we said in the intro. This podcast is going to be about a thoracic driver with poor foot and hip control. This is probably one of the number one things people message us about.
mhm.
So I thought we would just kind of take it apart a little bit and put it back together and talk about a few of some of our favorite interventions that we do.
Mm-hmm.
So
Do you want me
we're
to?
talking about a thoracic driver, in my opinion, and Erica's going to have her, her clinical expertise around this as well, is part of the thorax that isn't moving well, that is keeping the rest of the body or part of the body, making it either overmove or move in a way that is not optimal. And it's not, and so the pain doesn't necessarily land in the thorax, but it
Right.
but it causes motor problems down the chain or up the chain,
Yeah. Yeah.
and those areas can get irritable after
Mm-hmm.
time. If you're leaning out on one hip all the time, out over time, the gluteus medius tendon and some of the other things can get irritable. The bursa can get irritable. Muscles may not perform with great capacity because they're either in shortened or longer positions all the time. So, and that can, lead to, pain in that area. So we're kind of look at this with a little bit of maybe some hip pain, maybe some lumbar spine pain. But really, what are we trying to do? We're trying to get this system to function in a way that gives it more variability.
Yep.
And that means that we have to get after the thoracic driver,
Mm-hmm.
but we also have to train the body to work in different ways along with the thorax so that the body can change while we're changing the thorax. Go ahead,
Yeah.
Erica.
No, I was just thinking, we talk about center of mass so often on the
Mhm.
podcast, and I do take pictures of my patients still in normal, narrow, wide. I do it pretty much with every new patient and ongoing patient. And of course, nobody is going to be, centered. I mean, nobody is. It's life, right? But if you have done your assessment, if you have found that the thorax is the driver or one of the drivers, the body, what it does, there are a couple regions, the head, the neck, I'm sorry, the head, the neck area, the thorax and the pelvis. Those are the areas of sort of weight shifting or translation. In my opinion, the pelvis is less so, and the thorax is more so, along with the head. So if you are, for example, offloading a non-optimal foot, you have had a recent ankle sprain and you're offloading that foot, you will offload it the majority of the time via, I believe, at least this is what I see in your thorax. And so you'll sit there with this non-optimal movement pattern for many, many, many days, weeks, months, if you cannot get back onto that right leg for whatever reason, whether it's a, you're rehabbing it or just an old movement pattern. And so what the body does is it just says, okay, I'm going to offload my right leg or my right hip because I have poor control or I have an old injury, and I'm just going to go to the left. And a lot of times it does happen in the thorax. So, and I'll just have a quick thing. I'm treating an equestrian right now, and she, her non-optimal movement patterning in the thorax is also not just lateral translation or poor lateral control, is AP. So she's fallen off the horse twice. So she posts through her lumbar spine, which is not how you post on a horse. You post through the legs. So, and because of her shifting away from her right side for whatever reason, an old injury, she's posting anterior posterior with this left translation because of a non-optimal foot. She's on the horse, but this foot is still in you have a representation in your brain, right? So that I tend to see that quite a bit. So I would say just at the beginning for the listeners, take the pictures. If you see, whether it's AP or side to side, is it where is that thoracic, where is that translation coming from? Is it coming from the hip? Is it coming from, are you offloading the foot? Or is it just a dysfunction in the thorax? Do you want to expand on that, Susan, or should I keep going?
Sure. No, go ahead and keep going, because I think you're on a line here that's important.
Yeah. So I'll just do my equestrian. We'll do a big episode on her, but because, when I took a picture of I have access to a Pilates barrel. So I had her sit on the barrel, and she was way to the left, and I was like, no wonder you can't post through your right leg. You're already at the end range of your adduction on you can't do it because there's no, you're about to fall off. So, and then what she does is, and we talk about translation, she just shifts her head to the right to sort of center herself and not fall. Bear in mind, she's fallen off twice, right? So from a driver perspective, one of her drivers is her thorax, okay? And in order to restore or normalize or optimize the thorax so she can center herself on the horse, you have to treat that thorax.
Yeah.
However, she has lost options for movement on her right side. Okay, because it's working at end range, it's not really working at all. Okay, so you need to restore movement in the thorax with the secondary aim or goal of getting that right side to fire.
And I think that's such an important point, because I think this is where everybody gets confused. You've got, how do I know it's a thoracic driver when all of this is happening in the leg or the hip, or the foot as well? And, and it's because of it, it doesn't really matter at this point now what came first. This is the result that we have in front of us. So we can't just treat the leg and the foot without taking care of the thorax. And that's kind of, so this is where you'll run into this clinically. They'll come in with hip pain or foot pain and tell you this story, and immediately you'll go to where the hip and the foot is meaningful to the patient. You'll go to that point, but if you don't look above and see if there's anything else that's driving, which is why we call it the driver, that's driving this problem down low, then you're going to miss an important, you may get them better, but they're going to come back, and then they're going to get better and they're going to come back. And we're going to, so this is for the person who, or you treat it and it gets worse, even doesn't even get better, it gets worse. Then that you're looking too specifically regionally, and we need to get everybody to kind of look up. Is it a shoulder that's pulling the thorax over? Is it the thorax just simply being set over there like that? Is it, what's going on in that area? Is it stiff, or is it, just being held, stiffly through that area? And, talking about a posterior, load in the thorax, posterior translation, that's typically a posture that you see in pregnancy and postpartum.
Yeah.
That's why we see it so much in females. But
Mm,
males are not alone on this. They,
mm-mm.
how they carry, how they lift, how they move, they have their things as well that can pull them one side to the other. I see more lateral shifts in men.
Yeah. Yeah.
I think
Interesting.
in women, I
Yeah.
see more of the posterior lateral.
Yes.
Just because of the nature of who we are and how it works and all of that kind of stuff. But I think it's important to kind of like understand that, which is why we look at narrow, you know,
Normal
normal
wide.
and
Yeah.
wide, but we not just in standing,
Mm,
in movement. So we have them
yeah.
squat, narrow, normal, wide. We have them bend over, narrow, normal, wide. Yes, we're
Mm-hmm.
looking for neural tension stuff too. A
Mm-hmm.
neural tension
Mm-hmm.
piece can pull the thorax one way or the other, pull it back, pull it to the side.
Yes.
Um, which is kind of like, okay, so the underlying cause of that driver could be neural tension,
Yes.
but that's still the driver. We still have to get it to where it's not being pulled every time they step up on a step, because
Right.
if it's a neural tension problem and they're stepping up on a step, to go up and maybe pulling their thorax even further backwards or to the side, wherever it's going. And so then they're having, pain, in their hip because they're
Yeah.
being pulled into a position that maybe is making the femur grind, on the
Yeah.
acetabulum, or the foot is constantly loading on the side
Yeah.
as they're kind of going up or coming down.
Yeah. And I think also, if you see the normal, narrow, wide, even you can go on the wall. We talked about this many times on the
Hmm.
wall, hands, normal, narrow, wide. You have to clinically reason and say, okay, what's taking them there? And you'll know that based on the narrative, right? On their narrative and their movement and injury history. So I'll just use the equestrian as an example again. What's taking her to that left side? Is it the old right issue? I don't know, maybe. I think possibly, but I do think for her, the more non-optimal patterning at this point is more AP. So people who have thoracic drivers tend to really brace their scapula, and they're jamming the scapula when you just check seated trunk rotation. They're like, taking that right shoulder and, and, sort of retracting the scapula, which is not really pure rotation. You need people who have dysfunctional thoraxes and it's one of their drivers. You need to do scapulothoracic disassociation, like, a child's pose, a down dog. I have a lot of patients kneel facing the wall and do like a hands on the wall a bit higher, and then have them do a squat in kneeling. So you kneel like they're doing a bow, like a squat facing the
Hmm.
wall, just for that scap thoracic disassociation. So I think that's a little sort of tidbit there to, if people do have that, which is majority of people who have issues in their thorax. It's a great way to start, I think, start somebody's program.
Hmm.
And I also think that because you see a lot of lateral translation in this sort of population, you don't want to go down a rabbit hole and say, okay, but there, is what's taking them there? Is it truly a dysfunctional thorax, or is it truly like an old injury, or both? Right?
Right.
It could be an old hip injury, and that may have been the driver initially, but then they are doing something different now, and it's not the driver, right? So, this is how I would tease that out. You always are going to have a foot representation in the brain when you're sitting, right? Or in any position, right? So I this is just years of practice. I stand behind the patient and I close my eyes and I just sort of center myself with them. I just put I match my legs with their legs, and whatever that is. And I try to center them.
Hmm.
I move them posterior, anterior. I try to center them. And then I let go. And they're like, oh, and so you get a buy-in there, so you can go exploring other areas of the body,
Hmm.
in the initial assessment. That's what I do. Do I check seated trunk rotation a lot in thoracic drivers? Not a ton. Not in the assessment, to be honest. You were saying, Susan, earlier about squatting, like normal, narrow, wide squat. Those
Hmm.
are great ways you can see somebody's, it's a great full body movement. I mean, for the listeners, if you get good at one movement to assess, I would get good at that one.
Yeah. And so forward bend and squat can tell you a tremendous amount about the thorax, because when you get the thorax moving, their squat improves dramatically. And you never work
Mm-hmm.
on hip flexion, knee flexion, ankle dorsiflexion. It's
No.
amazing how it does. And same with bend overs,
Yes.
so
Yes. Yes. Yes.
you can get that to change quite a bit by working into the thorax. So some of the ways that we were talking about it was like scapular, motion and putting the hands on the wall. Because people always like, why do you put your hands on the wall? Why do you have them put their hands on a table? Why do you have them put their hands on things? And it's for that very reason, is to be able to change the input into
Yes.
the system so that if they have their hands on the wall, they're probably less likely to deviate, to go backwards or to go sideways or whatever it is that they're doing, because the hands give them a positional sense.
Mm-hmm. Mm-hmm.
And so they're not
Proprioception.
relying on whatever motor control pattern is in there that's pretty strong. They're having to adjust around that. So standing on one leg, somebody can stand on one leg beautifully. They stand on the other leg and it all falls apart because they don't have great control. Yes,
Mm-hmm.
we want to teach control in that hip and foot,
Mm-hmm.
but we go and put their hands on the wall and we see what happens. And they may start improving just by having their hands on the wall, which is a
Mm-hmm.
good thing. So that tells us that, okay, when we're going to work on hip control, let's put the hands on something
Mm-hmm.
so that we can begin to bring these patterns together and not have them be at the mercy of a driver that's not getting any input to it. That's
Right.
also the reason that we do the TheraBand around the wrists. And you can put them at different levels, eye level or chest level, depending upon what makes them work a little bit better.
Mm-hmm.
You can use walking sticks and have them progress to just a walking stick on one side or on two sides. Those are a little bit more jiggly, so they have to adapt a little bit more. Wouldn't start
Mm-hmm.
with those, perhaps. You probably would start with something a little bit more stationary,
Mm-hmm.
but you can have hands on the tops of chairs, like the backs of chairs as they're working on a lunge,
Mm-hmm. Mm-hmm.
as
Yep.
the wall would
Yep.
get in the way. So there's a lot of different ways that you could work on that. But that's the point and purpose of why we get the upper extremities involved.
Yeah.
And I know that you do some of that with just like doing, weights.
Yeah, I was just going to say that because the last episode we did was the little shorty on proprioception. So what Susan was saying about closed chain, putting your hands on the wall and on the table, that's a great way to increase proprioception, right? And another way to that I do a lot with patients, I have their back to the wall, so their butts on the wall, so their both butt cheeks are on the wall, and they have a reference for center. So that would be a progression of what we just discussed, right? So their back would be on, again, their butt would be on the wall. They're in this sort of bow position. And you can just have them do upper body work with the TheraBand in that position. So their butt is on the wall. That's the proprioception. So if they find that like one butt cheek is coming off, or if they're, going more side to side, they'll have that feeling and that somatosensory perception from the wall to know that, oh, I actually am deviating my thorax to the right, or I am going off center, or whatever, however they want to think that. But
Mhm.
that's another great way to do that, and up and just use the arms. And I was going to say something else. Oh, the another thing in the thorax that I found, or that I find, is, and I'm mostly with, I would say, a lot of people who tend to sort of very grippy in their thoraxes, is a lot of compression. Like I have a tennis player now I'm treating, he's got a lot of compression in his upper ribs, 2, 3, 4, very compressed, very common in like overhead athletes, mostly tennis players, things like that. So you may see this lateral translation that we talked about earlier, but you're also going to see a lot of compression, generally on their dominant side,
Yeah.
right?
Hmm.
So that's another thing that I think we should be aware of. What I do, Susan, I don't know if you do this, but those not yellow, those orange Franklin balls, I put them underneath their
Yeah.
armpits. And I'm
Hmm.
like, and some people are like really cool with that. And some people are like, oh, I'm really gripping. I'm like, no gripping. So that's not for them. But I mean, I like that idea. I think that's a great,
Hmm.
also proprioception, right?
Yep. That works really well, I think, because they get a different input
Yeah.
into their system.
Mm-hmm.
A lot of people will, grip their hands too a little bit. They're just seeking stability, and
Yep.
when you do some of this stuff, we're kind of giving them stability in a way that they can cope with it in a different pattern versus taking stability completely away from them,
Yes,
which is what
yes.
happens when they stand on one leg.
Exactly,
Their ability to
exactly.
stay stable starts to go away, right? And
Yeah,
so there's
yeah.
deviations and compensations. But when it's that radically different from side to side, then you know you've got to figure out where that's coming from. And it may not be that they may have poor capacity in the hip or the foot, but it may not be because of poor capacity in the hip and the foot. It may be because they're being drugged in a certain direction.
Right. And
And they can't cope with that motorically.
no, and I will tell you, so this equestrian that I'm treating, she's fairly centered now, but her anterior posterior translation. So she's been in the past, with other therapists working on abdominal control, which is very important for equestrians. However, they've been training her in her non-optimal pattern of this anterior translation, this bracing pattern, right? So and she's strong there. That's how she posts on the horse. So what I'm doing is, hear me out here, is I'm actually getting her, and this is kind of, I had her on her hands and knees, and I just had her do a sort of really like a round back, like posterior
Mm-hmm.
translation, really aggravate, because that's very hard for her to do. And I said, just kick your leg out like your normal or all fours leg. So her right side was her right foot in her hip. So she had issues with her hip, and she also had issues with her foot. Okay. So I had her on all fours in this sort of round back position. I said, kick out your left leg very slowly, keep the foot on the ground. Oh, no problem. No problem. I said, maintain. I had my hands, I was kneeling next to her. I said, really maintain this round back. She did her right side. When I tell you, Susan, she could barely move it. Okay. She's
Mm-hmm.
like, oh, it was shaking. Okay. So she is not strong in that position. She needs to be able to go in and out of AP translation in life, right?
Mm-hmm.
So my point is bringing this up, but we talked about the hip and the foot. She had very poor control there in that movement pattern. If I
Mm-hmm.
had her just do just flat back or even neutral spine, she wouldn't have a problem. And
Mm-hmm.
that's a key point. That's where she's been training, which is why she wasn't getting better with other people, right? So you want to think about with the thorax, yes, it's side to side, but once you clean that up, is there something else that you
Anterior,
need?
posterior.
Yes,
Yeah.
and in terms of, we talked about progressions, training, you're going to waste your time training her in neutral.
Mm-hmm.
I'll tell you that. I will tell you
Yeah.
that.
So this particular person I'm thinking of was when he runs, in the past, what would happen was this pain in his lumbar spine would be such that he'd be literally bent all the way over.
Oh, yeah.
Like just, and he had very strong thoracic driver. And we looked at everything. We looked at lunges, and you could tell on the one side he just like with a lunge when he would step out on the left and lunge the right, and it was time to come back onto the right, he just kind of gave up. He just like lifted up his foot and stepped back on it. I mean, that when he was hopping on one leg, you could tell from side to side how different it was, and he couldn't even like get his foot moving into a full point. And this was somebody who's trying to run. It's very
Oh boy.
strong, can adapt,
Yeah.
but finally was unable to adapt.
Yeah.
A
Yeah.
series of different things that have gone on in his life. To make a long story short, he's been working on hands and knees, opposite problem from what you just talked about.
Oh, interesting.
When he tends to like drop into extension because of poor hip control.
Mm,
So he uses lumbar extension to get hip extension in all fours.
mm.
So working to get him out of that, we had to work with the thorax, but we wanted to work in all those different positions. So he was doing lunges, holding on. He was doing, he had to back a lot of things down, but he was finally gaining control to where he could, actually extend, his leg without losing it in his lumbar spine. But his right side was still pretty fatigued. And so he kept working through that to get that going. We just lowered the leg some
Yep.
and did leg slides and some different things so he could regain some control with that threat, with the hands on the ground. And
Mm,
then did those things like you were talking about on the wall. He was moving back into child's pose and back forward. And could he do that with a semblance of control, or was he drifting?
mm-hmm.
He did much better when he tucked his feet up underneath him on all fours than if he let
Yes.
his feet be loose. He could gain control a little bit better. So to get him into some perturbation work, now that he has control through his central system a bit better, now I'm having him, he's on hands and knees. We have a Swiss ball against the wall. And so so on his right side, he's tucking his right foot under.
Mm-hmm.
He's extending his left foot, and so he can touch into the ball with his whole foot.
So the ball's against the wall and he's
Yeah.
facing away from the wall. Got it.
Yeah, he's facing away from the wall.
Got it.
And then he's bouncing the one side of his body. He comes up on his toe and goes down on his heel. And so he literally has to maintain control on
Oh,
one side while he's bouncing on the other. And we're doing that on both sides now to help him, because with running, we talk so much about running being, a one-legged thing, but there's control that has to occur. When one side is like up in the air, the other side is down on the ground, so
he's on all fours,
yeah,
the ball away from the wall. The
the
ball's
ball,
behind him and he's
uh-huh.
doing like plantar flexion, pushing into the
Yeah, like
ball.
kind of bouncing into the ball with his foot.
Oh, got it, got it. Oh,
Yeah,
that's
because the
great.
ball will give, right?
Yes,
So
yes, yes.
it doesn't have to be like crazy big movements. All you need is a little bit,
Yes, that's a great one
and
to
talk
do.
about proprioception.
Yeah.
He's got to maintain everything on one, through the body before
Mm-hmm.
or risk falling over,
Yes.
and so that's been kind of a fun thing to do. And of course, you can translate that up into standing, hands on the wall, stand on one leg, other foot on the Bosa ball, and just go up and down, or the trampoline,
Mm-hmm.
but you
Mm-hmm.
want to be sure that they're doing things that are helping them stay in the patterns that they want to move into, versus allowing themselves to just kind of go back to the old pattern and train it there.
Yeah, yeah,
So,
yeah. It's interesting because with the at least what I see with the thoracic drivers, a lot of them have inherent tricep weakness, but they also have an inherent abdominal deficit, right?
mhm,
And this equestrian certainly did, right?
mhm,
So very probably strong in like an anterior translation, but ended up getting her on I have a Wanda chair, the Pilates chair, in a prone pike position. So her hands were on the top of the chair and her feet were on the little pedals, and going into a pike position in that C curve where we need her to be stronger. And it's very hard abdominal exercise. And
mhm.
she was able to do it after multiple tries. And she's like, that's the first time I felt my abdominals without my back hurting. So you can get with especially with the thoracic drivers, you can get the abdominal. If you have a patient who you've progressed and they're missing something, I would look to some of the abdominal work, because that may just be inhibited, versus like a weakness. And like with her, I'm training it in that C curve, that posterior translation position, because that's where she needs it.
Mhm.
So I think
Yeah, and that's where downward dog and pikes, come in, really nicely. It's also where planks come in,
mhm,
because you certainly could do the same thing that I had this guy doing with his knee and foot on the ground, and I did that on purpose because he has a bit of hip and foot issue.
mhm.
But he's gonna try, we're gonna progress him to where he's in a plank, and he's gonna
Yeah,
press on the ball with the one foot.
yeah,
Because he
exactly,
needs to progress from a plank to hip extension on one leg on a plank, right? We need to keep
exactly.
progressing this driver. But those are you've got to have, like, you have to be able to recruit adequately through the central system in order for you to be able to do a nice plank and then be able to do the modifications off of it.
Yeah. So with Susan's example, my patient, so this just goes to show you how specific you have to be when you're dealing with the thorax. My patient, she's strong in a plank. There's no way I would,
Mhm.
like with her, like,
Yeah.
because you're absolutely right. They are complete the opposite. So with her, we're doing, not prone, pikes, C curves, things like
Hmm.
that in that position to recruit the abdominals, versus a plank, I would not give her. So, but that's the clinical reasoning. That's the beauty of the clinical reasoning, because abdominals are not just planking and piking, right? But it
Right. Or
has to be,
sit-ups. Right.
or sit-ups. It
Hmm.
has to be relevant to what's the word I'm looking for? The I want to say dysfunction, but their dominant pattern. You want to train them out of their dominant pattern,
Right.
because when you train them out of that dominant pattern, or you're training in that pattern, in their pattern that you need them to go, you will find deficits. You will find deficits. And, I think that's, what's the word I'm saying? I think that's where the rubber meets the road, especially when it comes to the thorax and any
Yeah.
region of the body, right? You need to use your clinical reasoning process and figure out what's the non-optimal pattern. That's their dominant pattern, basically. Where do they need to go for whatever thing they're coming in for? Do they need to be more centered? Do they need to be, do they want to run? Do they want to get on a horse? Do they want to play tennis? Things like that. And the exercise progressions are going to be based on you figuring out the dominant pattern and get it. I'm saying this not right. Their exercise progression should be based on the pattern that you want to get them into. And then whatever impairment that you find, whether it's a weakness of the right hip and right foot or a weakness of the foot control with your runner, you train them in that new pattern. Does that make sense? Yeah. And so I think that's why we wanted to talk about the thorax today, because it's not just all, side to side and rotations and things like that. I think it's important that you realize the pattern or the dominant pattern, and then train them in a position where you're trying to train them in a position. I'm having a problem with word retrieval today, Susan. You want to train them in their non-dominant pattern.
Yes.
That's my point. And that's where you're going to see the influence of the foot and the hip, because there will be weakness there, trust me. I think that's it, right?
Yeah. So keep your questions coming. We're happy to unpack them here on the podcast. And again, for those of you who have given us a review, thank you from the bottom of our heart. For our new listeners, please go in and review us on Apple Podcasts. It will mean the world to us to be able to reach more people and to have more people find us. So, all right.
Thanks,
Thank you,
guys.
and we'll see you next time.
Sounds good. Enjoy.